This presentation is on periodontal surgery. There are no absolute guidelines in deciding which cases should be treated surgically. In making the decision, the clinician needs to consider the likely reasons for persistence of pocketing, the appropriate remedies, the potential advantages of surgical treatment, the likely outcomes, as well as the patient's wishes and best interests. But the suggested indications are accessibility for scaling, to create good gingival contour for optimal plaque control, pocket depth reduction, apical repositioning of the gingival margin for restoration placement, to facilitate restorative treatment, and for regenerative or mucogingival procedures. The main objective of surgery is access. Surgery can facilitate access for scaling in certain areas, such as residual probing depths greater than 6 mm, multi-rooted teeth or teeth with more complex root anatomy, and furcation areas. Periodontal surgery is not a cure-all treatment for periodontal disease. There are several contraindications for surgery: poor plaque control, poor patient motivation and compliance, smoking, and special considerations for uncontrolled or progressive systemic diseases. Now we'll move on to the surgical assessment. Excellent plaque control is imperative. There should be no gingival bleeding. You need to assess the tooth vitality status and also take parallel periapical radiographs. Sometimes study models can also be very useful. Pre-operative considerations. It is vital to manage patients' expectations so that they will not have unrealistic expectations of the outcomes of their surgery. Obtaining appropriate informed consent from the patient prior to commencing surgery is crucial. The points that need to be discussed and understood include post-operative pain, discomfort and swelling, post-operative root sensitivity, longer clinical crowns, removal of sutures may be required, and commitment to long-term maintenance as well as good compliance. We'll now be looking at the principal stages of periodontal surgery. Number 1. Incision and elevation of full-thickness mucoperiosteal flaps, usually both buccally and lingually or palatally. Number 2. Removal of all granulation tissue within the defect and thorough root surface debridement. Number 3. If appropriate, correction of root surface anomalies and bone recontouring. Number 4. Replacement of flap and suturing. A wide range of surgical techniques and modifications have been described, and there is scant evidence to suggest that one technique is superior to another. Examples include open flap debridement, modified Widman flap, apical repositioned flap, and gingivectomy. In principle, most of the above techniques can be classified into two main approaches concerned with the surgical treatment of pocketing: pocket correction techniques and pocket elimination techniques. So firstly, we'll be looking at open flap debridement. Open flap debridement is a form of pocket correction. This technique depends on the principal advantage of periodontal surgery: direct access to the root surface to treat the pocket by achieving effective root surface debridement and hence allowing the pocket to heal. A flap is raised to allow direct root surface access. Following debridement, the flap is replaced as closely as possible to the original level of attachment to promote healing that will minimize recession. Pocket reduction results from the formation of a fibrous gingival cuff, long junctional epithelium, and some gingival recession. The modified Widman flap. One of the modifications of the open flap debridement technique is referred to as the modified Widman flap. Of the numerous periodontal surgical techniques, the modified Widman flap remains the standard procedure for open periodontal therapy. The method is characterized by precise incisions, partial flap reflection, and an atraumatic procedure. Because the alveolar process is only partially exposed, post-operative pain and swelling are rare. Number 1. Initial incision. Continuous, scalloping, submarginal and intrasulcular incision with no vertical releasing incisions. Number 2. Partial mobilization of the mucoperiosteal flap, full thickness, within the attached gingiva to the alveolar crest. Number 3. Second incision, sulcular incision. Number 4. Third incision, horizontal incision, also incidentally, and removal of the delineated tissue and all granulation tissue. Number 5. Root surface debridement under direct vision. And finally, flap adaptation, complete coverage interdentally. Post-operative care. Following completion of the surgical procedure, Patients must receive careful verbal and written post-operative instructions. These should include rest, appropriate analgesia to minimize pain and discomfort, 2% chlorhexidine mouthwash should be used 3 times a day, and the patient should be allowed to continue their normal oral hygiene elsewhere in the mouth. Soft diet for 24 hours post-operatively, and no brushing or incidental cleaning, and to avoid eating around the area of surgery for up to 14 days. Review appointments should take place 7 to 10 days after surgery. The frequency of review visits will depend on the patient's healing and oral hygiene status. Reassessment can take place from 3 to 6 months, and if successful, the patient can enter a maintenance program. So now we're going to briefly cover suturing. Suturing is an integral part to the practice of dentistry. Sutures are routinely used to approximate soft tissues and achieve hemostasis following periodontal procedures, as well as extractions, implant surgery, and soft tissue biopsies. A suture consists of a needle with an attached thread material. The parts of a suture are the cutting points, the body, the swag end, and the thread. The suture thread material can be natural or synthetic, absorbable, also known as resorbable, or non-absorbable, monofilament, or multifilament. The most common sutures in dentistry are coated Vicryl and Vicryl Rapide. Both are resorbable. However, coated Vicryl offers an effective wound support for 28 days with complete absorption at 56 to 70 days. Vicryl Rapide offers wound support for 10 days with total absorption by 42 days. Suture thread diameter is measured by gauge. This can vary from 10 to 11. The greater the gauge number, the thinner the suture thread and the lower the tensile strength. For dental surgery, we select the smallest appropriate thread size with sufficient strength to approximate the tissues in question effectively. 3/0 and 4/0 suture threads are commonly used. All this information is usually displayed on the outer packaging of the suture. This also shows the cutting shape of the needle and the length of the suture. Suture needles vary in shape of curvature. The most commonly used shapes in dentistry are 5/8 circle, a half circle, and 3/8 of a circle, with the 3/8 of a circle being the least curved. There are also a number of different types of sutures. These include simple interrupted, continuous, vertical mattress, and horizontal mattress. The most commonly used suture is the simple interrupted. Mastering this is important, as if this is done well, it can be used for most surgical procedures. The wound edges are held with tooth forceps, and the needle enters the tissues on one side of the wound and leaves on the other. Each suture is secured with a knot. When closing buccal soft tissue papillae by suturing to palatal or lingual papillae, when teeth are present, the needle must be carefully passed below the contact area of the adjacent teeth. This brings us to the end of this short presentation on periodontal surgery. For further information, please see our booklet. Thank you.